Hey everyone, thanks for joining Baltimore County Fire Department EMS Academy. My name is Sean Barinholtz. I am an anesthesia and ICU physician at Hopkins. I am an active volunteer at Pikesville Volunteer Fire Company in Baltimore County, and I have the honor of serving as one of the associate medical directors for Baltimore County Fire Department. On behalf of Dr. Andy Pollack in the medical director's office, on behalf of the EMS office, Chief Shenning, Captain Stewart, Captain Fitzpatrick, thanks for what you guys do every day. Thanks for being here. Thanks for your dedication to lifelong learning. A big shout out to Ashley Brooks. Ashley is one of our volunteers at Pikesville. She's going to be helping run our Zoom. She's available in the chat. She also is the one who will be sending out a link for your CEUs. So if you want your CEUs midway through this training, Ashley will send out a link in the chat. Click the link, enter some information, and get your MIMS CEUs. Yeah, I think that's about it. So tonight, super excited to have with us Caleb Ward. Dr. Ward is an emergency medicine physician at Children's National Hospital, where he holds an appointment as an assistant professor of pediatrics and emergency medicine. Dr. Ward completed his pediatric residency and chief residency at Johns Hopkins before completing his fellowship in pediatric emergency medicine at Children's National Hospital. He currently serves as the program director for EMS-C in DC and is a member of the Mayor's EMS Advisory Council in DC. His current research grants focus on improving the EMS care for low acuity children through alternative dispositions and treat and place protocols. He has presented at multiple regional and national EMS conferences. And I also know that he is an exceedingly dedicated educator with 3 young children at home, and he's still being able to do this. Caleb, thanks so much. We super appreciate you being here.
Thank you so much for the invitation. We're always glad to be here. Any of you with young kids will realize that when I said to my wife, I'm really sorry, but you're in charge of the 3 kids under 8 from 7 till 8:30 tonight, because I've got an education session I need to lead, will know that this was the easier of the 2 options by far. So, but I'm excited to be back here. I think it's been a couple of years, Sean and I were saying, since I was last with y'all. I'm going to pull up my slides in just a second. I wanted to do a big thank you, first of all, to any of you who responded to our request for volunteers for paramedic focus groups, because we had amazing responses, and I'm sure some of you were part of that team. So thank you for participating in that. The presentation today is going to be on pediatric EKGs and cardiac emergencies. Throughout, I'm going to throw up some EKGs, some clinical scenarios, ask you what you would do, what you think. If you want to come off mic and shout out, we go for it. If you want to drop things in the chat, I know in this virtual format that's sometimes the path of least resistance. I'll do my best to keep an eye on it as they kind of flash up as I'm presenting. But the more back and forth we get there, I think the more you will find you get out of it. All right. So, all right. Can folks see the screen? Give me a thumbs up if we're seeing some screens.
Looks
there.
great.
Good. I've got a thumbs up and you can hear my question. So we're good. All right. Let's get started. And by way of kind of timing, Sean and I were talking, and as adults learning in your own evenings, this for sure won't be going for 2 hours. My guess is we'll get about an hour or so. So learning objectives today. At the end of the session, my hope is that you're going to be able to talk about some of the common differences between pediatric and adult ECGs, EKGs, depending on which side of the Atlantic you're on. Recognize common EKG patterns for cardiac emergencies, and describe some of the initial management strategies that would be BLS or ALS applicable for pediatric cardiac emergencies. And throughout, I'm going to try and ground a bunch of it in either actual cases I've had or cases colleagues have had, and in a few cases I've had to stretch a little bit and make it more of a fictitious one, but trying to ground it in real clinical scenarios. One caveat here, you guys are experts in a lot of this, right? You see a whole lot more adults with chest pain than I do in my pediatric ED. So those kind of STEMI calls that you're going to be getting, 65-year-old guy with chest pain, you see that a whole lot more than me. And a lot of that is going to be applicable here. We just got to tweak it a little bit for the pediatric world. All right. So case 1. And this comes from the actual clinical bank that I have cared for this year. This was your colleagues in PG and a patient they brought to the ER. I do the overnight shifts, so it was about 3 a.m. when we got the kid. So this was a 7-week-old baby who was being fed by mom in her arms. The baby then gasped, looked pale, and per mom looked like they stopped breathing and became unresponsive. You can imagine that the rest of this history was obtained probably 24 hours later rather than at the time, because of the general amount of stress. So we've got an unresponsive, not breathing 7-week-old. No fevers, no injuries that mom was aware of. The baby wasn't a kid who had medical problems. This was a former full-term baby, pretty uneventful pregnancy, no medical history, no surgery. Obviously EMS activated. So the first unit on this scene was a BLS unit who found the patient to be in respiratory arrest, not breathing. They thought they could feel a brachial pulse, and I think we've all been there, right? Your adrenaline is up, the mom's adrenaline is up, they've got these chubby little arms, and you're like, I think, maybe, not sure, but they thought there was a faint pulse. And when they got leads on it, looked like the kid was bradycardic to the 40s. And the initial rhythm strip looked like this. So what do you think? Anyone want to drop in the chat, what does that rhythm look like? Back to kind of 101 cardiac EKG reading.
Almost like a VTAC.
Okay, almost like a VTAC, or like a VTAC, I'll take. Yep. Anyone want to throw out something different? Hold on, let me pull up.
I think it looks like course VFib.
Okay, cool. So we got a bunch of VFib or VTAC suggestions. The good news is, do I mind so much whether it's VFib or VTAC? Does it matter in your PALS algorithm? Nope. So another place you can start with this is shockable or non-shockable. So what are we thinking?
Shockable.
Shockable, great. Loving the interaction, keep it coming, guys. So whether or not these initial tracings are VTAC or VFib, what the key thing I think to recognize here, this is not one of those flatline asystoles. And so this is the shockable line of your PALS algorithm. When was the last time anyone shocked a 7-week-old? I'll put my hands up that my answer is never. This is pretty uncommon. And then later on, we'll talk a little bit about the kind of epidemiology of pediatric cardiac emergencies. But a shockable rhythm in a 7-week-old is pretty uncommon, which is why this case stuck out to me as a good starting point today. Can you throw in the chat, or someone can verbalize, what would be your other initial steps of management?
Say that again.
So 2 things Sean is putting in there. You would need to shock me.
Chest compressions.
Good.
Check a glucose.
Okay. Glucose, chest compressions, shocking. What else? Bagging and chest compressions. Great. I love that you guys are thinking both that it's shockable and the compressions. There's a tendency to, often we get one or the other. We're like, this kid is in arrest, we need to start our chest compressions. Or, oh my gosh, this is one of my shockable rhythms, shock. And then sort of everyone steps back and expects some Lazarus style, biblical, they wake up, smile, thank you for saving their life, and then you go about your business. That's not typically what happens, right? So it's shock and then right on the chest. And getting those chest compressions, bag valve mask ventilations, and then eventually once someone has got the wherewithal, someone thinking about H's and T's. So I like all of that. Access, what do you think? 7-week-old in arrest, you're shocking them. What's your go-to going to be here?
I'm going to IO them.
Yep. I like all of the IO answers. We're obviously in a different boat in the ED where we have I'm never doing this with more than, I used to say like 7 or 8 people, but with recent staffing, you won't be surprised to hear that I'm going to say more than 5 people, but I've always got a bunch of people in the room. But even then, so usually we will try to look for an IV at first. But in a baby of this age in arrest, I can't think of the last time they didn't need an IO at some point. So often I have colleagues who will go straight to an IO, or others who will give folks like a 60-second window. And if they haven't got their IV access, then we go straight to the IO. All right, so you guys were all over what this one was. So let's look a little bit about what actually happened to this kid. Much of what you were talking about, chest compressions and bag valve mask ventilation, IO access was placed. Eventually, when there's a provider on scene who had the credentialing and skills, intubation with a 3.0 cuffed tube, they defibrillated with 8 joules, and we'll come back and talk about that a little bit more. In the pre-hospital setting, they gave amiodarone and epinephrine, and they got ROSC. So they brought the kid to the ED, and really most of the work had been done. In the initial blood work we got, this kid was real acidotic, right? So this was an actual arrest in the field. Lactate was 13 and the pH was 6.9. Their blood pressure was poor, hypotensive, so they needed a bunch of fluids and some epinephrine. But then it became a little more interesting, and this is the kind of weeds of it that, you know, this is more kind of the, what really happened, doc? This kid ultimately ended up having flips of persistent tachycardia that looked both narrow and broad complex. So the cardiologist got pretty excited. The kid got various meds, flecainide, propranolol. They did the echo to look at the structure of the heart. It looks normal. They sent off a bunch of genetic tests to try and figure out if this kid had some genetic reason for having a weird heart rhythm. That all came back negative. This is the crunch line though. The CT and the MRI of this kid's brain was normal without any signs of injury. As an ER doc, I could not have achieved that. This kid got to where they did a normal neuro at discharge with a normal CT and MRI because the EMS providers who were caring for them got the leads on this kid, recognized that this 7-week-old baby had a shockable rhythm, shocked the kid before they arrived in the hospital, and had ROSC. This is a once in a career type thing, but the pre-hospital providers' treatment for this baby for sure was, if not life-saving, definitely life-altering. So hats off to them, and I think a good reminder to you to always think shockable, non-shockable. Their working diagnosis was ultimately, they thought it was a supraventricular tachycardia with some weird conduction rather than a VTAC for reasons that fancier cardiologists than me would be needed to fully understand. But the kid's following up in cardiology clinic, and when I checked it today before giving this presentation, good neurological outcome. So that's the dream, right? So let's talk about a couple of other cases, and then we'll get into the weeds more on some EKGs. So we've got now a bigger kid. 7-year-old girl collapses at soccer. She wasn't witnessed to have any obvious convulsions of her arms or legs. No apparent trauma. There wasn't like a major head injury, didn't run into the goalpost before this happened. And the screaming parent on the sideline is saying that she has no medical history. 911 called. We'll give you that the initial management is a given here. CPR, bag mask ventilation, and an IO was placed. Before we think about the EKG, this is obviously electron cardiac stuff, so you're primed to think about cardiac differentials. What sort of differentials are you thinking about? What could have gone on to lead a previously healthy 7-year-old girl to just collapse at soccer?
Sugars, maybe.
Okay.
Respiratory.
Okay. Tell me more about a respiratory cause that would cause her to go sudden tip over.
Well, if she was, if she had an unknown history of asthma or
Okay.
an unknown respiratory, something obstructive or
So
something.
she was just kind of girling through her game and then totally fell. Sure. No dumb questions at all. Could it be a collapse from allergic? Yep, for sure. You don't always have to have the hives element of it.
How about an unknown cardiac anomaly?
There we go. Undiagnosed. Yep.
Yep. And then so undiagnosed cardiac abnormality. The other place I would think about something undiagnosed would be, so we've got SVT, so we've got people getting into the weeds, great, of the types of things. The other thing I would think about is something in the head. Truthfully, if someone's well enough to start a soccer game, the respiratory stuff for sure could be possible. I usually feel like I get more of a history with those ones. And ditto with the allergy, anaphylaxis. Often you're looking for those other things, right? Vomiting, hives, lip swelling, but sometimes you get caught out by it. When I think of something sudden going on, and a couple of good ideas, recent COVID and then myocarditis for sure. Again, I'd expect a little more of a history of a lead up, right? Like maybe the chest pain, exercise intolerance. Someone has dropped in cerebral. When I think of like sudden going from normal to not responding / arrest, it often triggers me to think about blood flow related things, right? Because that's the sort of thing that can turn on and off. So bursting of some kind of vascular anomaly in the brain, or obstruction of vessels. Yeah, no, did she take a soccer ball to the chest is a good question. Not that we were aware of. So brain bleeds and kind of sudden cardiac stuff in terms of someone who literally just goes from running around a soccer field to collapse would be where my brain goes initially, but the rest of your differentials are all good. So here's what her EKG looks like. So back to our previous question, shockable, non-shockable.
Looks like
Shockable.
Shockable.
Shockable, great. It's not a flat line of asystole, and that for sure ain't organized electrical activity of PEA. And I think a couple of folks asking in terms of torsades, because it has that appearance of the rotating axis there, which is all excellent. So you guys were right on the money there. So concern for a shockable rhythm with BF. Let's just talk a little bit about the PALS algorithm for those of you who this applies to. So we've started CPR, you've given oxygen, you attach the monitor, you've decided it's shockable rhythm, right? So you're down that VFVT side. You're not sweating the details of which of those two it is. What comes next?
Your meds.
All right. Tell me about some meds.
Epi 0.01 milligram per kilogram.
Oh, he's dropping in doses is everything fancy. Okay, good. So
Sorry.
Epi, no, go for it.
Magnesium.
And we're getting mag as well. Good. So you're thinking about that, and we'll come to more meds. Amiodarone is the other key one in PALS. The key is to remember there's that frequent shocking, right? So it's shocking back on the chest, compressions, and that's one of the most common things I see even in the hospital setting that is not done correctly. People shock, the kind of shock back on the chest is the verbiage I use when I'm trying to lead teams in the ED. Another 2 minutes, recheck. And truthfully, I think of it as a rhythm check. I tell the team to think of it as a rhythm check rather than a pulse check. We're checking for the pulse, checking for the rhythm. If they remain shockable, they get shocked again. And then for me, I just do the meds every 4 minutes. I don't know why we say every 3 to 5, because you're stopping every 2 to check. With epinephrine and amiodarone, and then thinking about your meds. So let's just talk a little bit about defibrillation. How much, when you defibrillate adults, how many joules are you using?
Are you talking unsynchronized?
Yes, unsynchronized. Yes, unsynchronized shock as opposed to synchronized. Yep. How much? Starting with 200.
200, 300, 360.
360. Yep.
Good. So we have consensus on that. 200, 300, 360. How much are you doing for kids?
2 joules per kilo
Per
for your
kilogram.
initial shock, and it goes up by 2 joules each subsequent shock, if memory serves me correctly.
Good. So this is why we do this, right? Because you're right on the money. You're getting the. And what's your max joules per kilo you'd go to?
100.
Oh, max. So you're talking about 100 joules as opposed to joules per kilo.
Correct. Yeah.
Okay. Yeah, most PALS
Sorry.
talks about a 10 per kilo limit there. But remembering that you're starting off at 2 joules per kilo, second shock 4 joules per kilo. And then most of us, I can think of only a few times in my career where I've needed to get up to that higher end of that range. Yeah, 2, 4, 6, 6, 6, 8, 10. Yeah, beyond the 4, you can do whatever numbers you want to make a pattern in between 4 and 10, John. But you guys are getting the right first of 2 joules per kilo. One of the challenges in the heat of the minute that I've seen trip people up can be, you do the math, you've got the kids, so they're 5 kilo, no, that's not a good example. They're 7 kilos, you do 2 times 7 is 14, and then you're pushing the button to change the numbers, and it won't give you 14. Never worry about you're basically rounding up. But in the heat of the moment, I've seen people get tripped up on it. So it's 2 joules per kilo rounded up to whatever the nearest joules that's available to you is. So 2 joules per kilo, 4 joules per kilo, pediatric, unsynchronized defib. You don't need this because someone's already given you the meds. 0.01 mg per kg IV for epi, which amounts to 0.1 mil per kilo. amiodarone arrest dose, 5 mg per kg, and then lidocaine is the other one that you'll see used. I've included here just a flag to one of the studies that we just published in the last couple of weeks using Maryland data, just to flag that epinephrine is a high-risk med, and we often see dose errors. So we looked at 1 year's worth of data in Maryland for kids, and if there wasn't a weight documented, 55% of the kids had a wrong epidose, and if there was a weight, it dropped to 35%. So please get a weight on these kids, and just be aware that epinephrine is a high-risk med, so you can't overdo trying to drill these numbers into your mind. At the same time, I think people who are responsible for writing these protocols and running EMS agencies and developing PALS algorithms, we probably need to figure out more creative solutions so that you're not doing quite as much math at the bedside, because you do a whole lot more than I have to in the ER and the code bay. All right. So that was 2 separate cases, both showing shockable rhythms in kids. Remember, you can't see it, although it's uncommon in little kids. We're going to switch gears a little bit now. Fussy baby, 5 weeks old, sent from their primary care office because they were concerned the kid seemed to be breathing fast. Thought they had a bit of a murmur, but not much else. And then the mom was like, yeah, this kid doesn't feed us well. And this was mom's second kid. She said, it's just harder to get this kid to feed. He seems to get tired when he feeds. The pediatrician had got some vital signs. The temp was 37.2. This is a 5-week-old baby whose pulse was 180. Their respiratory rate was 70. And their oxygen sats on room air were 92%. And the blood pressure that they could get in the office was 115/75. When you listen to the chest, you are concerned that it sounds like there's a pretty significant murmur, a systolic murmur, and you've got an EKG that's coming up. So someone's dropping in 92%, so need oxygen. And you're not going to do, not true. Almost always you're not going to do a whole lot of harm to kids with oxygen. Truthfully, shortest transport time. But I'm not going to fault you if you're getting oxygen on. There are complicated reasons with kids with cardiac lesions where actually this might be as good as your oxygen's going to get, but I don't want that to be your takeaway. Andrea, excellent question. Do you mind coming off mute and telling me why you asked this one about, do you want to sat on both arms?
With the age of the child, you'd want to see if there's a preductal and a postductal difference.
Yeah.
To see
awesome.
if.
And where would you get your preductal?
Oh goodness, on the right side, I believe is
Perfect.
preductal.
Yeah. Yep. So right hand, and then the other one, any of the other places are postductal, but your right hand is your preductal pulse, which is gives you a really valuable pieces of information. So if you go with both hands, you're not going to go far wrong, and it gives you. And we're going to show some pictures of anatomy. We'll go back to Anatomy 101 class as to why that's important in kids. But great question from you. For what age range is this a concern? We'll talk about that in a little, Daniel. The duct typically closes over those first few weeks of life. It's certainly in newborns, in that first month or 2 of life, you want to be thinking about that. All right. So now we're going to do a couple of sort of rapid fire, normal, abnormal, baby EKGs, because frankly these are weird. These trip up docs of all stripes, and pediatric ER docs no less. Pediatric cardiologists are going to have this down pat, but anyone who's not them, we need a lot of practice. So I'm going to throw this one up here. Baby EKG number 1, normal, abnormal. Feel free to just chuck it in the chat, or if you're spotting anything that catches your eye that you want to follow up on, and we can look at it together.
Abnormal.
Abnormal. Someone was confident on that. What do you think is abnormal?
I'm looking at V1. What am I
Tell me
seeing
about
there?
V1.
Okay, so I mean, granted, I'm just what they joke is an EMTI incomplete. It looks like almost like there's a heart block of some sort, but
Okay.
I mean,
Yeah. The cardiology term for that is going to be an RSR, that like kind of squiggle there between in the way that you're seeing the QRS complex there. I
Yes.
like your eye went to it. We got a few other suggestions. John wondering about some hypertrophy. What's making you wonder about hypertrophy, John?
Sorry, I had to unmute. I'm looking at the size of the QRS complex.
Yep. Okay. So
And
those look.
the inconsistency in it over the V leads.
Okay. Okay. What do people think about the T waves?
They're flipped, but on a pediatric EKG, you put V3 on the right side of the chest. Does that make the T waves flip?
So you guys are spotting exactly the right things, and you're almost right and right on the money with your explanation. So the thing to spot here is that these T waves are flipped in 1, 2, and 3. You had an adult patient you were running that had flipped T wave, right? QRS is going. Let's look at V3. QRS is pretty clearly going up there. T wave is pretty clearly flipped. You saw that in an adult patient, you would have a pretty concerning differential. But in kids, this is normal. So this is actually a normal EKG for a baby of this age. We see flipped T waves in children, certainly V1, V2, V3. It can sometimes go further. And certainly in young kids, school-age kids. Usually by the time they're teenagers, that's changed. V1 can sometimes still take a long time. So sometimes we'll see teenagers where V1, that T wave is still flipped. But that is less concerning to us. Part of the reason for this is the physiology. We're going to come back to this with one of the other cases. But when babies are born, their right ventricle, which pumps the blood to the lungs, is working against a lot more pressure than it does later in life. All right. So let's flip and look at a different version. Normal or abnormal here?
Well, almost looks like you have a first degree block because it like V3, it just seems like there's a long
Okay. So your eyes go into that. How long is the interval between
the PR interval?
Yep.
Right.
So we could bust out our calipers if we were so inclined to have them. I'll tell you this one, I think looked longish, but ended up being okay. Anything else catching people's eyes?
Narrow QRS. Maybe?
Narrow QRS. Yep, it's okay. It's on the narrower side, but not too narrow. Inverted P's. Where are you seeing your inverted P's?
What about your peaked peak T waves?
Peaked T waves. The T waves or the P waves? Which ones are you thinking there? Those P waves up in.
Tall. I'm sorry, I'm having a block. The tall, like QRS, like the. Sorry, my brain is having a fart.
You're good. Do not worry. At the risk of, let me just get my, here. Sorry, I'm just going to draw it. All right. You guys can see me drawing on it?
Yep.
So these P waves here, there's not actually much to see by way of a T wave here, pretty flat looking. Those P waves certainly look a little generous. While we're up here though, normally, which direction is the QRS complex going in lead 1? Up, right? And yep, someone else's, yeah, so we've got some leads some QRS complexes that are a little weird. The other place they're doing this is there's one other lead there, you can see it, AVF. Let me stop doing that so I can come back to here. Good. So in lead 1 and in AVF there, you've got QRS complexes that are not doing the normal direction that you'd expect. So this tells us that rather than the normal kind of up from the atria down and then into the left ventricle, the direction of electricity in the heart here is doing something funky. For the medics, this is what's called a northwest axis because of the way those QRS complexes are going. And this tells me the baby is at high risk for having an AV canal defect. but you already knew that because the kid had a murmur, they had lower sats than you were expecting, and you did what, I think it was Caroline, someone mentioned putting a pre and a postductal sat on, and you had figured that out already. This is just how we get our extra confirming bias in the ER. All right, let me see it. Now I knew that I shouldn't annotate. Let me erase what I did. There we go. So we said EKG, and I just showed you there the key problem with that axis. And then finally EKG, and then we'll go back to a little less eating your cereal. EKG 3, normal or abnormal? What do you think? This one's a little more subtle.
What's all that noise in the P wave? Like it's weird looking on V1.
Agreed. The kind of shape is a little, whenever you see a wonky shape like that, sometimes you're trying to wonder if it's kind of got two peaks to it. And that can tell you that there might be some delay defects in between the atria.
I mean, you kind of see it in V2 too. It's like it kind of scribbles out like a bad mountain.
Mm-hmm. Someone has noticed inverted T waves in lead 2. Which is, yeah, I'll take that. So I'm going to cut to the chase on this one because it's a little more obscure. This kid and these are pretty deep T waves here. So the kind of shape of these is off, and something about the shape of that clearly caught your eye. And I think part of it is this divot down here. And that is because that's what we see sometimes in babies who are having Alcapa. So this is just sort of background, one of the common anomalies to be aware of in kids. Not common, but serious. Sorry, I should have misspoke there. So normally your coronary arteries are sending oxygenated blood to the heart, right? You don't want blue blood going to your heart muscles. And normally your left coronary artery you see on that screen left comes off the aorta there. What happens in anomalous left coronary artery is it comes off the pulmonary trunk. And that's normally the one sending your deoxygenated blue blood to the lungs. So this means this baby's cardiac muscle is getting perfused by deoxygenated blood. So you can imagine that makes for a pretty unhappy myocardium. And basically is not dissimilar to what is happening in older folks when they have atherosclerotic lesions in their vessels, causing ischemic heart disease. So this is basically sort of the thing that causes little babies to present having the equivalent of a myocardial infarct. Super weird, but I throw it in for one of the kind of quirky PEDS cases that we can see. Quick basic overview of electrophysiology. I feel like we should try and find out who's the freshest grad from school and they can walk us through this one, but in the absence of being unkind. So you've got electrical impulses starting off at the sinoatrial node, right? Working their way through the atria, getting to the, oh, good question, Andrew. Transposition of the great arteries. Yes. So that's where the pulmonary trunk and the aorta come, instead of off the ventricles they're supposed to, they come off the opposite sides. So that one is a more wholesale restructuring of the plumbing. The Alcapa one is more of the vessel to the actual heart coming off the wrong place. Good question. So our electricity starts off the sinoatrial node, goes through the atria, gets through that AV node, and then comes down through the interventricular septum there, Purkinje fibers, and gets out to the myocardium. And what we're seeing when we do our EKGs is a reflection of that. But what's important to think about is why fetal circulation is different. So in adults, or basically anyone who's not living inside a uterus, actually, you get your oxygen from breathing, right? And your lungs have that critical role, but the plumbing in kids is totally different. So where are they getting their oxygenated blood from?
Umbilical cord.
Yeah, right? So it's coming from the placenta, from mom, all of those I would take as answers, right? So you've got that bright red blood coming from their placenta through the umbilical vein, up through the ductus venosus in the liver, all the way up through the IVC. and dumping itself into that left side of the circulation. And in utero, when babies are in pre-birth, what's going on in the lungs? What are they filled with? Air?
Fluid.
Fluid. Yep. So they're these like fluid-filled spongy things. And that is not really where you want to be sending a whole lot of blood. So rather than have your right ventricle, which you see there, that kind of pinkish color, instead of pumping all of that blood to the lungs, we bypass it, and that duct. So you see that ductus arteriosus there, right where the pulmonary artery bifurcates. That diverts the blood so that it can get into the aorta and to the rest of the body. That is supposed to close after birth, right? Because after birth, we start having these two parallel circuits working. Your colleague who said, what if this is a duct problem? That's why you want to get the right hand, because that will give you a sense of, is there a difference pre that point where the duct joins the descending aorta and post? Because your left arm and both your legs are going to see what your oxygen sat is after that. So just to recap what happens when babies are born. This is my middle child who always is right, the poor middle child, not the oldest, not the youngest. So I promised him he would get the picture in the presentation today. But what happens when they're born? So they're born with these water-filled lungs. What happens?
They go through the birth canal, all that stuff gets squeezed out.
They cry.
Yeah, both of these,
Well,
right?
yeah, they cry.
So we say it like they cry, and we're like, yeah, a lot of all of that happens, right? There's a whole bunch of physiological stress from transitioning through the birth canal. And then they cry, and they take these huge screaming gulps of air. And as they do that, they're bringing in air to their lungs. That water gets, the kind of fluid in there is getting reabsorbed. And they suddenly have air-filled lungs. And that makes it a whole lot easier for blood to get pushed to the through to the pulmonary vessels, right? Because the pressure there goes down a whole bunch once you've got a bunch of air in the lungs. So if you're ever having the misfortune of doing deliveries in the field or seeing babies right after birth, just have in mind that this is kind of what you're up against in terms of their lungs. It's why their oxygen sats aren't normal when they're born. And it's why you want to think about a pulse ox on your right hand in addition to the rest of the body. Though truthfully, we know that getting them anywhere on these guys is different. So let's just take a little bit of a step back from some of those cases and key abnormalities and review this a little more systematically. Pediatric EKGs can be different in some, none, or all of these. What do we think? Rate, rhythm, intervals, amplitude, axis, morphology. Are kids different in all of these? Some of them?
Probably all.
All is going to be your safest answer, right? You're like, there's some pediatrician here who thinks it's a good idea for us to talk about this for a while. Yeah, in general, all of these. So let's start off with rate. How do you think that's going to be different in kids?
Higher,
right? And you've all got those hopefully reference values that you use. Truthfully, I don't think there's a whole lot of point in trying to memorize them, long as you've got some ballpark that the younger they are, the higher they are, but it's an important reference point. Where that becomes real tricky is things like SVT, where a kid with fever and dehydration can have a heart rate that looks real high and can be sometimes pretty hard to distinguish from other things. So higher heart rates. What about rhythm? That's probably the hardest one.
All right, I'll be first here. Is it because as their heart is sort of growing, they're going to have different morphologies based, from beat to beat?
So I'm going to give you that one. So actually, kind of in general, the electrical wiring of the heart is the electrical wiring of the heart, right? That doesn't, in the same way, it doesn't really change a whole lot. So then in general, the kind of P wave followed by the QRS and the T, there's slight differences in how long those intervals are supposed to take, but it doesn't change a whole lot. One thing that does change actually, though, is that you can get more beat-to-beat variation. So we would call that sinus arrhythmia, and in particular in teenagers. So healthy adolescent athletes, often you'll get what looks like kind of real, like pretty short interval between the QRS followed and kind of variability there. So we see a little more variability in the sinus arrhythmia there. And then the intervals, someone was jumping in there, and so I'm going to go straight to that. But yes, so a shorter PR interval and the QRS duration. So those can both be a little bit shorter. And then we can see a slightly longer QT in little ones, almost in the up to 500 range in infants who are less than 6 months. But I think your key things are rate, often greater than 100. I mentioned the SVT challenge that it can pose, rhythm, sinus arrhythmia, and intervals. So then let's switch over. Axis, in general, remember those figures we just looked at, the kids in utero are pumping all of that blood to the lungs. Aren't pumping that blood to the lungs because it's got a whole lot of pressure. So they tend to look like they've got right axis deviation. They've got a dominant right heart when they're born, and we think about seeing that on the EKGs. Then morphology, not a whole lot here, looking for Q waves in the inferior precordial leads. But in general, that RSR prime that folks were sometimes wondering is, are we seeing bundle branch block? Those T wave inversions, the right axis deviation, just remember in your little kids, the kind of less than 6 months, all of that just is what we call a right ventricular strain pattern. So that very first set of EKGs we were looking at that were tripping us up a little bit about normal, abnormal, that's something I want you to remember. All right, so that's the end of the kind of dry portion of basics of EKGs and how they're different for kids and adults in physiology. Let's flip over to a case now. Case 4, 1-year-old, party hat time, irritable, poor feeding for about a day. And the mom now thinks this kid looks pale and tachypnic.
Without even looking at an EKG, my first thought is SVT.
Okay, and where'd you get that from? What made you go there?
The heart rate.
Yeah, so you saw pulse 300, right? So it's, how do you even count that? Yes, probably, right? So this is one of those we're getting leads on, is probably going to give you that number. It's not quite going to feel like a buzz, but it's going to yes, quickly I'll also take. No history of heart disease, no family history of heart disease.
Is there a temperature? Is there a temperature?
Yeah, afebrile.
Oh, okay.
It's a
Thank
good
you.
question. There are algorithms that allow us to kind of discount the degree of tachycardia with fever, but you ain't getting to 300.
That's what I was going to say. Even with the fever, I work in an ER, and I worked in a pediatric ER for a long time. Even with the fever, you're not getting to 300.
The group where I'll sometimes find it more challenging in the sort of 3 to 6 month old group, when they are febrile to 40 and dehydrated, for sure we will then sometimes see it around 200 or so. And that tends to get a lot of people scratching their heads and looking at the monitor and wanting to see the leads and an EKG to make sure that we're not missing it. 300 is tipping everyone. Yeah, so if you want that as your, once you're north of 200, it's a fair game to start worrying about these. What's the other vital sign I'm probably really interested in here? It's showing.
The respiratory rate?
The blood pressure.
All right, what do we think? Yep, I think both of those are fair. I'd probably go to the blood pressure, right? Because it's gonna change my next steps a little bit more in terms of if this kid's real tacky, but keeping his blood pressure okay. What do you think? 80/56 in a 1-year-old? Thumbs up, thumbs down?
70 times, 70 times 2 times 4 times their age, and
No, you got it.
I
70
remember
times
the
2
formula.
times the age. 70 plus 2
2 times the
times the age. You got it.
Yeah.
So, I mean, it could be okay, but if it's okay, it's on the low side of okay, in my opinion.
Yeah, I think one of the challenges we have, right, is we often actually just chart high blood pressures in kids, and because we're so used to adult 120/80, right? We could chart, like, we would chart 115/70 in this kid without batting an eyelid. Plenty of times those kids would get discharged from our ER. That's a way abnormal blood pressure for a 1-year-old. Whereas 80/56 means they've got a relaxed child, a good cup. Like, they actually probably, that's a pretty good normal heart rate for a blood pressure for a 1-year-old. The key is I'm not worried about that systolic. That's not a super low systolic.
No, it's the diastolic, which is low.
Diastolic's a little lower. But for now, I'm okay with this blood pressure. And then this is your EKG.
Well, I'm going with my original thought before I even saw it, SVT.
This is a one where you were primed to look for it. So we were going in thinking SVT. When we think that, what are we looking at our EKG for?
P waves or the lack thereof because they're buried.
Yeah, anyone seeing P waves?
Nope.
Me neither. And then someone saying QRS in lead 6 in lead V1 looking weird. Agreed, there's a little divot there. Agree. Too fast to see. Yeah. All of those are reasonable. The other things we look at, kind of we bust out a paper and put our little pencil markings and look, is there any beat to beat variability? Because when you're in true SVT, you're normally seeing kind of this automaticity to it. And if you do that here, you don't see any variability. So this was indeed SVT. Challenging diagnosis to make in kids who are pre-verbal, right? The folks who are older will give the sensation of, if they're still mentally alert and normal blood pressure, they'll be like, my chest hurts, it feels like my heart's beating fast. 1-year-olds aren't doing that. And so it can be a more challenging diagnosis, especially if their parents haven't accidentally felt a pulse, and why would they truthfully, if they've not got any background, or even if they do have a medical background, it's not where your mind goes to in a 1-year-old who's been irritable and pale and a little tachypnic. So how are you going to manage this kid who's in SVT?
Light them up.
What's that?
I was joking. I was saying light them up, but I mean, it's,
I mean,
Any other-
his blood pressure is okay. You could probably make a case for adenosine.
Okay, so we've got light them up, by which I'm going to take some electrical therapy. We've got another vote for adenosine. Any other votes? Anything
it's
you
hard to,
tried?
like a
Sorry.
Valsalva, but it doesn't really work with a 1-year-old.
Good. Good. So those are
0.1 milligram per kilogram.
perfect. Blowing in their face. Yeah. So kind of, I think you guys are
Oh,
describing.
you know what else you can do?
What's
You
that?
can douse them in ice.
Yeah. So all of these are your kind of, as certainly if you're in the emergency department, the things that are up your sleeve, and you're thinking about all of the management things that I want you to think about. In general, I wouldn't spend a whole lot of time on the vagal maneuvers in a 1-year-old. I've seen teams get a little bit monitor and transport. These kids can tolerate these rates for some time. Again, a not unreasonable comment. And I can think of a few cases where it's ended up being more challenging for us when kids got adenosine pre-arrival in the hospital, and we didn't have the rhythm strips we needed to ultimately try and make our final diagnoses. I think that will depend a little bit on your transport time, that blood pressure, and all of those things. The question about vagal maneuvers in kids, it's hard, man. And I've seen teams get really derailed by spending a lot of time trying to find all the ice they can in the ED. The thought of the kind of sudden blowing on their faces, you can also just trigger more of that vagal response. I've never seen that help or work, but it's certainly listed as one of the things you can try. In older kids, what are some of the tricks you might use?
Blow into a 10 cc syringe.
Yeah, it's my go-to is the syringe one, right? So people talk about like, try to bear down. Like if I taught my 7-year-old would just burst out laughing, or if they were sick would just be confused, right? Like try to bear down like you're going poop. Like it just doesn't get us very far. Giving them a 10 or a bigger syringe and having them blow in it is my go-to there. And then adenosine, someone mentioned. So what are you going to give them for adenosine? How much?
0.1 milligrams per kilogram. For your
Up
first
to?
dose, and your subsequent doses is 0.2 milligrams per kilogram.
Yeah. And then anyone else want to chime in with what your maximum first dose and second dose? So 0.1 mg per kg
It's-
up to
It's 6, right?
whoever
It's
invented
six.
it. Yep, and then 12 for the second. Whoever invented adenosine and the dosing, I feel like this is one of the doses that people have always got right at their fingertips. And no shame if people haven't, but 0.1 mg per kg and 0.2 mg per kg. So pediatric SVT causes a multifactorial. About half the kids have a totally normal heart. About a quarter of them will have a particular defect called Wolff-Parkinson-White. And then another quarter of them will have a history of congenital heart disease, and they have abnormal electrical wiring in the heart because of that. So your narrow complex tachycardia, is your clue here. Infants, the heart rate can be anywhere in that 220 to 320 range. And then the older children, 150 to 250. Question from Howard, is it really worth trying to get an IV or doing an IO on this child? Tell me
So
what you think.
I'm just gonna say something about IVs. I mean, adenosine has a really short half-life, and you have to have an AC, otherwise you don't get it to them fast enough. So that's a good point.
Yeah, it is one where I think sort of, in general, I think appropriately, right? There are times when IOs in alert, not cardiac arrest cases are needed. The challenge here is that the adenosine needs to hit the myocardium and the electrical wiring there fast and in a concentrated time span. So actually the way I usually do this when I'm doing it in the emergency room is have people set up a 3-way stopcock with a saline chaser linked to the adenosine. So it's adenosine switch and then an immediate push of the saline after it. And then, yes, the largest bore I can get in the upper extremity. I've certainly seen cases where we were not able to get anything in the upper extremity and have then had to sort of make do with lower extremity, but it certainly makes everything a lot more challenging. All right, so we talked a little bit about how this kid presented. In general, kids can actually tolerate SVT surprisingly well, which means sometimes they present, and when you push the parents on the history, they've been in SVT for some time. It can be a day or two sometimes, but fussy, poor perfusion, not feeding well, pale. And then you guys talked about all of the management. You're right on top of this. Vagal maneuvers with an asterisk there because I don't want you to get too hung up on it. Adenosine 0.1 mg per kg and 0.2 mg per kg. And then when the kids are showing me instability, so that's why we talked about the blood pressure, that's when I'm starting to think about synchronized cardioversion. All right, last case, and then we're going to talk about some general cardiac arrest management tips. 4-month-old infant found unresponsive in bed. The history as best we can get it was co-sleeping. EMS was activated. Initial management was bag valve mask ventilation and chest compressions. And we've got someone jump in. Thanks, Tess, for jumping right on it. Check airway, start CPR immediately. So that is all correct. We will leave for another day the discussion of intubate versus supraglottic versus bag valve mask ventilation, partly because there's no good answers there. But what I want to pivot to a little bit here is the population, the stats and the outcomes and what makes a difference and what doesn't. So what are this baby's chances? This is basically either co-sleeping, smothered, suffocated, or SIDS. There's overlapping circles here. But we've got a 4-month-old out of hospital cardiac arrest. What are the baby's chances of survival?
Sadly,
Slim.
not very good. Slim. Yeah, slim to none.
Slim to none. All of these are fair. I include this not to say we shouldn't be doing what we're doing, but I think it's important to remember that failure to get, it's not like if you follow these steps, you'll get good ROSC every time. This is an important poor outcome, and if they do, poor neurological outcome. Yep. And sadly, we've not made much difference in this, despite a lot of research, a lot of public education, a lot of focus over the last few decades. So the follow-up question is what things that you do or I do in the ED might make a difference?
I don't know. We're not quite there yet, but what about induced hyperthermia? Hypothermia. Make sure I had that.
Yeah, so you are in the next and more advanced lecture of hypothermia. People have been looking at this for a while. In general, the data is not all that promising in kids. I really like Andrea's comments. Tell me a little bit about what you mean by how we treat the parents.
Well, they're going to have huge guilt. And I think Andrea's point was really good. I mean, I've worked in a pediatric ER. I've seen way too many. And, you know, I know what we all think. So how we treat them is huge, because they have to live with that the rest of their lives if it's a negative outcome, and usually it is. So that's we need to treat them respectfully and gently, and
Yep. It was not what I was expecting, but I actually think it's an incredibly important point that sort of even when we know this is unlikely to result, a case that's unlikely to get ROSC, this baby is likely going to die.
Hey,
and-
doctor.
Yeah.
So it's interesting because I just went through research for my paramedic, and one of the things we covered was how do you deal with death, basically, and not so much the EMS provider, but how do you deal with everybody that's in the room besides yourself? And this may or may not be germane, but one of the things they discovered is that when the patient dies, regardless of age, an average of 7 minutes, we are gone from the scene from the time of death to back in the rig. And one of the things we were discussing in this particular module was that take the extra time.
Yep.
The baby, the mom, the dad is already dead. Take the extra time. Make sure you clean up everything. So just kind of parroting onto and adding onto what Carol and Andrea were saying. At that point, take the extra time. And just comfort. I mean, that's what part of us is. We are patient advocates. Take the extra time.
I think you're all hitting on some really important points. I want to just flag two of them in particular. Ben dropped something here, and it is germane to two ways. Ben mentioned kind of stop running to the ambulance, doing ineffective resuscitation, kind of start your compressions and work in place. The sort of, and I don't like the terminology of stay and play because you're not playing, you're providing medical care, but that stay and play versus load and go debate, very much the data is coming out for both pediatrics and adults to get proper on-scene resuscitation done initially, that you cannot do great compressions while bundling someone along, getting them into a vehicle, compressions in the vehicle are less. So kind of really doing that initial assessment and stabilization and giving yourself a little bit of time there to do that. Jennifer Anders from Hopkins, the Associate State Medical Director for Pediatrics, is one of the national leaders in looking at the literature in this and trying to push the needle for kids. But also, I think the other point about if there is, the vast majority of time with kids, people are still working the kids until they get to the ED for a range of reasons, including that we've got many more resources to deal with the complexity of the social situation after death is declared. But if you are declaring at the scene, obviously doing that per protocol. Maryland has a pretty robust termination of resuscitation on the scene protocol that's been covered a lot in the national literature. Taking your time with families, being very concrete verbiage around your baby's heart has stopped. And clear language, expressions of sympathy are all really important things. We could talk for a long time about a lot of that. Just shifting a little bit. So just to underscore some of the points we made about the baby's chances and things like this. So pediatric cardiac arrest epidemiology in the US. So there's about 16,000 pediatric cardiac arrests per year in the United States. And that works out to 10 per 100,000. The highest risk group is infants. And I don't think that'll be a surprise to most of you. When I think of the deaths that I've declared in the ED, the older kids, there's medically complex kids, there's trauma, but the sudden infant death, smothering, co-sleeping, those infants are a really large chunk of cardiac arrest that we see in pediatrics, 73 per 100,000. And what do you think is the most common initial rhythm?
Asystole.
Yeah, so asystole, occasionally PEA. That's why I included that first one, because we can all use reminders of the uncommon. But the vast majority of times you are not shocking these babies. It's a non-shockable side of your PALS algorithm, asystole, PEA, in 85% or so of cases. And currently the data, 6% or so survival to hospital discharge, but infants are worse. So they're at 3%. It's better, someone mentioned this, was there a witness to the arrest? Obviously better if there's witnessed arrest, 13 versus 5%. and better if there's bystander CPR, 9 versus 5%. But these numbers are abysmal. They're worse, remember, for the young infants who are the most common chunk of our patients in cardiac arrest. These numbers haven't really improved, depressingly, over the last few decades. We talked about some of the kind of social stuff that makes a difference, just drilling down on some of the medical stuff that makes a difference. Continuous high quality chest compressions, and that's where the staying on scene, getting good initial resuscitation is important, getting your access, getting your first dose of epinephrine. A lot of the data here, and this is from fancy journals from some folks at Hopkins, JAMA and stuff, is extrapolated from inpatient cardiac arrest because it's obviously fiendishly difficult to study out of hospital cardiac arrest. But first dose of epi, if you get that in less than 5 minutes, at least a 10 percentage point bump in survival, 33 versus 21%. So taking that time to get access and get your first dose of epinephrine in is critically important. And then quick shockable, your time to shock is important as well, if it's a shockable rhythm. Any preference for pad placement on peds? No, where would you normally be putting your pads in an infant?
One on front, one on back.
Yeah.
Anterior, posterior.
Yep, anterior, posterior. There's newish studies showing that outcomes are not inferior with smaller pads that may in the future give us more ability to do the 2 anterior positions, anterior and axillary, without needing to roll the baby over to get that pad on the back. The key is not having the pads touch, and that's just harder to do within axillary and anterior chest positioning, especially in the very little kids, given the size of the pads. So this is the last key point that I want to discuss. High quality chest compressions. It sounds obvious. How often do you think we're all doing high quality chest compressions? And this is all of us, hospital, EMS, the lot.
Not so much, but it's
yeah,
getting
why
better.
not? What do we do? Why is it not good?
We either don't push effect deep enough or too much and allow for appropriate I'm going to use the word rebound, but I can't think of the right word right now.
Recoil.
Thank you. Recoil.
Yeah. Okay. So don't allow for chest recoil. What else do we think? How do we think we do with rate normally?
Not fast enough.
Too fast.
All right, so we got one. Anyone else want to chime in? We're splitting the votes each way so far. Too slow, inconsistent, go from too fast to too slow.
I want to recount on the votes.
And I think that we might not rotate enough.
Yep.
Because you think that it's a kid and you can stay on the chest longer. So
I really like John's point about too many breaks between compressions, which we are all bad at. One of the things we're bad at about is rhythm checks, the kind of rhythm pulse check, and then taking way too long to get back on the chest. In the pre-hospital setting, it's a little more challenging, right, in terms of your ability to rotate and switch. But we can get good data about how good we are with this with the zone monitors, right? So most academic medical centers that are using this have QI programs now where we get all the data. So anytime I lead an arrest, I get a report from our QI and safety manager showing what the performance of the team that I was leading was in terms of the compressions that were delivered. And so this is a paper from about 10 years or so ago, looking at the percentage of, they kind of took a cardiac arrest scene and chopped it up into little blocks of time and said, how often were we doing the right thing by rate and depth and all those things? So you see here, rate was only about half the time they were getting the rate right. In general, from most of the studies I've seen, the vast majority of the time we're going too fast. You may have the odd provider or an occasional scenario where we're too slow, but almost always the adrenaline kicks in and we are way fast. Depth is the same thing. Almost always we're too shallow. So it's almost always these fast, too shallow, not actually getting real depth and allowing recoil. The chest compression fraction, the proportion of the time that you're getting effective CPR, because they've got those pauses, and then leaning, especially when you're tired. The other challenge in a moving vehicle, adds to that. But ultimately, only 8% of the time was the rate and the depth good and no leaning. So we are in general poor. What do you think might make a difference to this in real time? Any thoughts? Because this is concerning, right? It's basically the only thing you can do that is going to make a difference to the vast majority of kids in cardiac arrest. Most of them are non-shockable. Pediatric crews, feedback that compresses.
Early effective CPR. It's almost like I'm.
I like.
No, but I
John,
think you need to rotate your compressors more. I mean,
Yep.
people
So
get tired and they think
Yep.
they're okay. And they're like, no, I'm fine. But they really do need to rotate to keep up the effective compressions. But when you do rotate, make sure you're rotating quickly and less than, limiting the amount of pause.
Yep. I just want to make sure folks saw in the chat that there was a question about the Lucas in terms of your age cutoff. It looks like it's 12 from Sean, so it's in there. And so, John, I really like lots of good suggestions from the team. Rotating, using metronomes, having a CPR boss and a pit crew. And I think a lot of the data that I have seen says that if you've got someone giving feedback, things get better. Now, that's obviously easier in my land where I've got extra bodies and I can take the third-year resident who has done enough chest compressions in their career and say, your job is to monitor that zone, because it gives you data, right? It tells you how your rate's doing. It tells you how your depth's doing, whether you're getting enough recoil, and have them monitor for rate and depth. I will come and put you to bed soon. It tells you they are supervised at the moment. It tells you whether the rate and the depth are okay. And you see here, the dark shaded bars are if someone's giving feedback. The pale ones are if there's no feedback. You have someone saying, slow down, look at your rate on the ZO. You can get the chunk of times when they're getting the right rate up from 30 to 80. And depth, it's a little bit harder, but you can, and in particular with rate, you can make a big difference. And so those are the things that I want you to keep an eye on there. All right. For those wanting to dig a little bit deeper, a lot of the EKG pearls I took from here, I am ripping off from PEM Academy. So if you just search PEM Academy and EKGs, it'll give you, it's a site maintained by the fellowship team at Children's National. And along with some cardiologists, they have developed these EKG modules. They're short, bite-sized, the sort of thing you could do in a break, like 8 minutes or so, most of them. And a lot of them have stop and plug and play options for you to review an EKG, see if you can spot what's wrong, not wrong, and then gives you feedback afterwards on it. So the website is down there at the bottom, but I think it's a great resource if you're looking to dig more into your EKG skills. So my wrap-up summary for pediatric cardiology cases for you would be, remember your in utero physiology. Babies' right sides of their hearts are working hard before they're born. Newborns aren't supposed to have normal pulse oxes. Don't forget to put something on the right hand. Your pediatric EKGs are different. So they're going to have different rates, certainly different rates, rhythm, intervals, and then the morphology reflects the fact that that right side of the heart's working harder. And then pediatric emergencies are cardiac emergencies are different. Sorry, let me just flick back. Oh, sorry, someone was asking for that website again, and I don't want to leave you hanging. So it's pemacademy.com/ECG, or if you just search PEM Academy, it'll bring it up for you. All right. So pediatric cardiac emergencies are different. They've got different causes. It's not your myocardial infarct from ischemic heart disease in adults. Their presentation can be different. They're not always going to present with crushing chest pain spreading down their left arm. It may be those cases we talked about where the toddler just seemed off and wasn't feeding. And your management's different. Remember, your drugs and your joules are different. Your joules 2 per kilo to shock, up to 10 per kilo max. And remember, depressingly, that outcomes are poor, but that doesn't mean that we shouldn't be working to do a better job on our compressions and making sure that we're communicating compassionately with families. My email address is there. I'm always happy to take follow-up questions. Sometimes people end up having cases that they wanted to kind of think about or drill down on more. If you're ever involved with transporting kids to us, I know it's not going to be your norm, but we have a great base station coordinator, Emily DeRose, one of our nurses, who's always happy to help with feedback to teams. I'm going to stop sharing now so that I can field any questions that you all might have.
Caleb, that was excellent. That was excellent. I always learn something. I love these series. Thank you so much.
You are very kind. Let's see what's popping up in the chat.
So one quick question, one quick thing for the folks. So don't forget to sign in using the link that Ashley has sent out a couple of times now in the chat. So take a look at the chat, click on the link, enter some information, get your CEUs.
The question about, as we see more obesity, do we see more pediatric MIs? Not really. We see high blood pressure, we see kidney disease, we see diabetes, but not typically the myocardial, the kind of true myocardial infarcts.
What is the youngest age for an AICD?
Gonna pass on that. I will say that typically, if any of our kids are getting those sorts of devices, they're usually followed by an email to anyone who might work in the emergency department or critical care to flag and to alert our cardiology team.
Hey, doctor, thanks again, especially
No.
from a pre-hospital provider. It's good to just have this refresh.
You're most welcome. Really glad to get a chance to chat with you all.
Thank you. Super appreciate you.
I will let you all get back to your evenings, but feel free to reach out. Always happy to come back and teach you all formally in this setting and informal work. And
We have a couple more on the slate with you and Cindy, so I'm excited for that.
Awesome.
Maybe you don't know about it yet.
Cindy and I work pretty closely together at the moment, so.
I know. She's great. Thank you.